In this podcast, we will learn about science and physiology behind CPAP, called as continuous positive airway pressure. The other name of CPAP is continuous distending pressure, CDP. In this, one applies pressure to upper airways in a spontaneously breathing baby in both phases of respiration, inspiration and expiration. Let us understand how CPAP helps a preterm baby. In a baby with RDS, the functional residual capacity of lung (FRC) is reduced as alveoli collapse at the end of expiration. CPAP increases the FRC, decreases the ventilation perfusion mismatch, thus improving oxygenation, washing out CO2, improving the pH. It splints the upper airways, preventing obstructive apnea, dilates the lower airways, thus reducing the airway resistance. Overall, tidal volume improves and the work of breathing decreases. With improved physiology, the pneumocyte 2, which produce surfactant, functions better with better recycling and production of surfactant. This reflects as improved lung compliance in long run. Let me share with you 4 animal experiments which will convince that CPAP is better than conventional ventilation. Here is a preterm lamb lung in which alveolar septa are damaged following 24 hours of ventilation. Though the FRC is increased following ventilation, but the effective surface area for gas exchange has decreased. In preterm, the alveolar wall is thin with less supporting tissue, hence more prone to damage. Notice in this preterm lamp, following 72 hours of conventional ventilation, the interalveolar wall thickness is 3 to 4 times when compared with another in which nasal CPAP is given. With thickened alveolar wall, the gas exchange will become difficult in this preterm. With conventional ventilation, acute lung injury sets in. As shown in this figure, within 2 hours, the alveolar lavage shows significant higher amounts of inflammatory cells and free oxygen radicals when compared to another lung in which bubble CPAP is given. This 4th experiment shows compliance of preterm baboon lung treated with surfactant within 24 hours and ventilation. Compliance is change in volume per unit change of pressure, meaning a stiff lung needs higher pressure for unit change of volume, meaning the lung has low compliance. Following conventional ventilation for 28 days, due to lung damage and fibrosis, the lung becomes stiff. Thus, compliance is reduced, as shown in green line, as compared to another lung in which CPAP is provided. The lung is distensible with better compliance, as shown in blue lines. Conventional ventilation results in ventilator-induced lung injury, also called as VILI. The greatest hazard to preterm baby lung is due to endotracheal tube, causing biotrauma. In conventional ventilation, many alveoli at end of expiration collapse due to low peak and expiratory pressure. The sudden opening and closing of alveoli leads to atelectotrauma, while in CPAP, due to constant continuous pressure, this injury is minimal. Conventional ventilation causes barotrauma due to high mean airway pressure and variable peak inspiratory pressure, while in CPAP, pressure delivered is much less. Unregulated tidal volume in conventional ventilation causes volutrauma, while in CPAP, baby is breathing spontaneously, deciding the tidal volume. So, Willy occurs due to biotrauma, atelectotrauma, barotrauma, volutrauma to premature baby lung. CPAP is like a magic. It opens the lung at FRC for better gas exchange, keeps the lung open with minimal pressure than in conventional ventilation, thus causing less of barotrauma. Baby is breathing spontaneously, deciding tidal volume. So, no volutrauma. But most important, as there is no endotracheal tube, no biotrauma. Pulmonary artery pressure are least with improved blood flow, hence less ventilation perfusion mismatch. Let us understand the relationship between lung volume x-axis with pulmonary vascular resistance y-axis. PVR is least once the lung is open at the FRC. At this, blood flow is maximum with best ventilation perfusion matching and gas exchange. You can see on right, baby with meconium aspiration syndrome has higher lung volume, while on left, hyaline membrane disease has lower lung volume. Both result in high pulmonary vascular resistance. In clinical practice, for a baby on CPAP with higher pressure, the lung will overdistend, while low CPAP will cause reduced FRC. In both, PVR will increase, causing right to left shunt, impairing pulmonary blood flow. Thus, we must ensure lung is opened at FRC for best blood flow and better gas exchange in a baby on CPAP. We must understand one important physiological principle, that is law of Laplace. According to this, the pressure by which alveoli tend to collapse is given by formula 2 times the surface tension divided by radius. The smaller the alveoli is, the higher will be inward pressure by which it will tend to collapse. Imagine two alveoli are connected to same terminal airway. The smaller alveoli will have tendency to collapse and empty into larger due to higher inward collapsing pressure. Notice right smaller alveoli has pressure 6 centimeter while left bigger one 4 centimeter, as the radius small r is 1 and 1.5 respectively. In a baby born, the alveolus are lined with water molecules which tend to pull alveoli towards center. This can be nullified by CPAP pressure or by reducing the surface tension by giving surfactant. And if both are done simultaneously, synergistic action can be obtained. This has gone into clinical practice and is called as ensure intubate, give surfactant, extubate to CPAP. We learnt CPAP is safe as it causes less lung injury, as was shown in 4 animal experiments, and the harms of conventional ventilation in terms of avoiding biotrauma, barotrauma, volutrauma, and atelectotrauma. One should give optimal CPAP to open the lung at FRC as pulmonary vascular resistance is least with maximum blood flow. Use of surfactant and CPAP is beneficial in babies with RDS. You will learn now that CPAP will give maximum dividends if you use antenatal corticosteroids for preterm labor, have good delivery room practices, use early CPAP, and have team of dedicated nurses and doctors managing sick baby with RDS. Thank you.